Welcome back. We'll finish up looking at the respiratory system here, and we'll start to take a look at how air coming in the lungs can be obstructed in a way. And so we have one of the things that we talked about back with the cardiovascular system was resistance. And resistance plays a role here as well, as the airways themselves can become obstructed. They can have issues with the ability for the air to move into the airways themselves. And so this is one of the things that's going to potentially impact the ability for our lungs to become inflated. And so when it comes to resistance, similar to that of the blood vessels, we start to take a look at the diameter of the blood vessels themselves. And so once again, we have our autonomic nervous system playing a role, and this is going to be our parasympathetic stimulation or our sympathetic stimulation here. And in the lungs, when we start to talk about the smooth muscle involved in our smaller bronchi, we start to see a parasympathetic activity that causes contraction of those smooth muscles. So this is going to cause bronchoconstriction. So we're going to go from essentially a wide opened airway to having something that is now smaller. And so the diameter is smaller. So this is going to increase the resistance that's there. Versus our sympathetic pathway is going to go from a constricted airway to a nice wide open airway. So we're going to get bronchodilation. The smooth muscle is going to relax, and this is going to cause the airways to become nice and opened. We're in a sympathetic state. We're in fight or flight. We need to be able to get air into the lungs. This process involves two separate types of receptors that we've talked about before. We have our muscarinic receptors, and then we have our beta 2 receptors, causing this occurrence within the smooth muscle themselves. So this is either going to generate a nice wide open bronchial. This is our sympathetic activity. And then a constricted activity, rest and digest, parasympathetic activity. And so two different types of processes that are going on there, leading to a different amount of air needs. And so rest and digest, those bronchioles can constrict down. We can have a situation where we don't have to get as much air flowing through those vessels. Essentially, it's going to be more difficult to get the air to come through there. Some diseases cause this in a sense on their own, or the result of the disease is something that causes this to happen as well. And so things like bronchitis end up having an effect on the airways themselves by not only causing not bronchitis, but asthma. But with asthma, we have a constriction of the airway in that the smooth muscle is decreasing the size that is there. But we also get a situation at times with different kinds of asthma where we also have mucus buildup. And so even if the airway is, in a sense, the same diameter, if we end up with something kind of stuck to the inside here and taking up space inside there, like mucus, that's going to effectively reduce our diameter. And so the diameter is going to be smaller than what it potentially should be, simply because we have excess mucus in there. If we throw in there something like an allergic type of asthma, and we've got an inflammatory type of condition as well, all the more it's going to decrease the amount of space that is there for that to occur. And so other things like chronic bronchitis are going to reduce the size of the airways, also add in the inflammatory aspect and the mucus along with it. So the constriction on the airways plays one role in terms of getting air into the lungs. Another factor that plays a role in terms of our getting air into the lungs is the compliance of the system itself. And so compliance simply is essentially kind of, you can think about it as kind of how stretchy is the system, how easily is the system able to become inflated as the air is coming into the lungs themselves. And so the lungs themselves have a degree of elasticity to them. And so they are able to expand and contract kind of like a balloon. If we could change the elasticity of the balloon kind of On different occasions, we may be able to blow up the balloon easier or harder, and that's just simply the elasticity that is there. Inside the lungs, remember that we have those little alveoli, and in those alveoli we have water. And so there's a little bit of fluid that's inside there. That fluid that's inside there creates water tension. And so that water tension is the thing that when we look at an alveolus, when we have that little bit of water that is there, if the edges start to approximate one another, the water is going to further pull in on the sides and potentially collapse our alveolus down. And so we're going to have that space, in a sense, filled up, and it's no longer going to be inflated. And so that surface tension is in there, and that tries to pull the alveoli closed. We combat that through the production of surfactant. And so surfactant is a detergent that, similar to detergent that you use for cleaning things, it reduces the amount of force that we have on that surface tension. And so instead of having a big force, it makes it essentially have a little force. And so our cells inside the alveolus, the alveolar cells, are producing that surfactant. It, in a sense, kind of lines the layer there as well with the water, and it makes it so that the tug of the water isn't quite so great. It's not going to pull on it as much as if we didn't have it there, which is something that can occur with like premature babies. And so preemies have the potential to have a decrease or an absence of their production of surfactant, and that can cause their lungs to collapse. And so it can cause a decrease in that force that's there that is normally being changed by the surfactant, and we now have the potential for collapsing of the lungs. So when we get this gas into the lungs themselves, when we look at what we want is oxygen. What we need to get rid of is carbon dioxide. But when we look at essentially the air itself, air has oxygen, it has carbon dioxide, but those make up a small portion of the total of all of the air itself. The majority of air is actually nitrogen. And then we have the next largest chunk is oxygen. And then the next largest chunk is actually even a combination of both carbon dioxide and everything else that's in the air. And so we have very little that's there. When we look at this whole, in a sense, column of air, we can kind of think about the world. Here we have our ground. Let's have a little tree here. And then we have somewhere up at the top, in a sense, the top of the world. And so we've got some clouds up here. And all along there, we've got all these different types of gases. And each one gives a certain percentage of the total that's there. And every gas has a mass to it. And so each one is kind of pushing down on us with a particular amount of force. Nitrogen giving us the most amount of force, and then a little bit from oxygen, and then a tiny little bit here in the end from all the other gases that are there. So it's almost as if we're in a fluid, and that fluid, similar to that of like an ocean or a lake, the further down into the fluid we go, and so the further into it we get, the more, in a sense, above us there is. Which means that when we're at sea level, the total pressure is 760 millimeters of mercury. And so we're able to push the amount of air pressure that's around us, pushes a column of mercury up 760 millimeters. And so it raises it that amount. As we go higher, and so if our elevation goes up, and we get higher in elevation, then there's basically, if we were to move upwards here, let's make another. So we've got like up in the mountains now, there's less of this column of air pushing down on us. So the atmospheric pressure drops. When it comes to exchanging of gases, the two that we're concerned with are oxygen and carbon dioxide. And so those are the two that we need to think about in terms of the total column. So the pressure that oxygen exerts on our body comes out to be approximately 160 millimeters of mercury. The amount of pressure that carbon dioxide pushes on us comes out to be approximately 3/10 of a millimeter. And so not very much at all. And so we have these changes that are there within the system itself. And as we go up or down again, there's either going to be more or less of the oxygen or carbon dioxide in the total system itself. And so what this does is it allows us to diffuse oxygen into the capillaries and carbon dioxide out of the capillaries. Because out here in the alveolus, we're going to have a partial pressure of oxygen that's going to be somewhere in the neighborhood of 105 millimeters of mercury. And in here, we're going to have something like 40 millimeters of mercury. And that big gradient is what's going to drive oxygen into the capillaries. And that's going to push it. Just like when we have a concentration gradient, that concentration gradient pushes the substance from the higher concentration to the lower concentration. The same thing goes for partial pressures. We go from a higher partial pressure towards a lower partial pressure. And this allows us to make that push in a very quick manner. So that as we're running through this capillary, the blood only takes about 1/4 of a second for it to become completely saturated with oxygen. So we have a very, very fast movement through the system itself. Where this is occurring in the lungs, this is what we call external respiration. And so oxygen is going from the alveoli into the capillaries, and carbon dioxide is going from the capillary into the alveoli. The converse happens, or the reverse happens, when we get into the tissues. And so at the tissue level, we're now going to do internal respiration. And so internal respiration is going to allow us to deliver the oxygen to the tissues and pick up carbon dioxide from the tissues. And so now inside the capillaries, we now have roughly 105 millimeters of mercury of pressure on the oxygen. But in the tissues, we're down to 40. And so that gradient, once again, pushes the oxygen from the capillaries into the tissues. And just the reverse is going to happen for carbon dioxide. Except with carbon dioxide, the numbers are going to be a little bit different. Inside the tissues, we're going to be at a 45 millimeters of mercury. But in the capillary, we're only going to be at 40. And this allows us to still quickly move carbon dioxide into the blood, simply because carbon dioxide, in a sense, is easier to dissolve inside the plasma. And so it's easier to get carbon dioxide to move into the tissues, from the tissues into the blood, than it is for oxygen to do so. So this is where, for carbon dioxide, when we get back to the lungs, we have a PCO2, or partial pressure of carbon dioxide, of 45. And in the lungs, we have a partial pressure of only 40. That still allows for all of the CO2 to be able to be dumped off into the lungs. And so we have the ability to blow off all of the processes that we have through external respiration. External respiration for the oxygen, in this particular picture, we have 100 millimeters of mercury and then 40 inside the capillary. And this comes to one of those situations, again, where it depends upon who you're reading, which book you're looking at, as far as the pressures that they're going to give you in order to look at the differences that are there. But at any rate, oxygen is very quickly pushed into the capillary, and then it's going to end up going into our little red blood cells, and we're going to quickly oxygenate them as they pass through the capillary bed. And again, just the opposite occurs at the tissue level. And so now we have a partial pressure of oxygen here of 95, partial pressure of oxygen of 40, and that's going to very quickly dump off oxygen into the tissues. And so whether that's a muscle cell here, looks like an adipocyte, some sort of epithelial tissue, whatever they happen to be, it's going to feed all of those tissues with enough oxygen and pick up all of its carbon dioxide that it needs to. This process just goes simply in reverse. In order to get the gases to move throughout the body itself, we have red blood cells. And so the red blood cells have contained within them hemoglobin. And so hemoglobin fills almost the entire inside of a red blood cell. And so discounting water, basically the whole inside of that red blood cell is all hemoglobin. And we looked at this before when we looked at the blood cells and saw just the vast quantity of hemoglobin that's inside there and its ability to carry around oxygen. And so we have that inside there. A small amount of oxygen is just floating around in the plasma. The majority of it is going to be bound to the hemoglobin. This occurs because oxygen likes to bind to hemoglobin. And so oxygen and hemoglobin are attracted to one another. And depending upon environmental characteristics is going to dictate essentially how easily oxygen stays bound to that hemoglobin itself. And so the oxygen stays well bound to hemoglobin, and we get 4 oxygen per hemoglobin if the temperature is cooler and if we're not really doing anything, low carbon dioxide levels. So as we come into a tissue, that oxygen is going to stay on those hemoglobin molecules if it's cool. So if the temperature of the particular tissue is cooler, as well as if the body isn't really doing anything in that particular area. And so if metabolism is low, carbon dioxide levels are going to be low, and therefore oxygen isn't going to dissociate from the hemoglobin. But if we raise the temperature of a particular area, so now say a muscle is working, that's going to increase the temperature locally in that muscle. Carbon dioxide levels are potentially going to start to rise, and that's going to cause more oxygen to leave the hemoglobin. And so it gets released into the tissues themselves. Because we have a warmer temperature, we have a higher CO2 level, which is going to mean that our pH is going to decrease as well. And so that's going to lead to the offloading of oxygen into the tissues at that time. The majority of all of that oxygen, again, was carried by hemoglobin. With carbon dioxide, the hemoglobin isn't going to be the primary carrier of the carbon dioxide. And so carbon dioxide is transported not as carbon dioxide, but as bicarbonate. A small percentage gets carried by the hemoglobin itself, so it can bind to the hemoglobin. When we have that, we get what we call carbaminohemoglobin. Fun word to say. Say it 5 times and see if you make it through it all. And rather than on hemoglobin, though, we're going to convert that carbon dioxide into bicarbonate. And so we have a reversible reaction that takes our carbon dioxide and transforms it into bicarbonate. It has an intermediate step where we end up with carbonic acid. And then that carbonic acid, as we go out into the plasma, converts into bicarbonate. So the majority of that bicarbonate is not only not on the hemoglobin, it's also in the plasma. So it is in the plasma itself. As we go in the opposite direction and come back towards carbon dioxide, this is going to reduce the amount of carbonic acid that we have in the blood. And this is going to make it so that we have a raising of the blood pH. And so the more carbon dioxide that we get rid of, raising of the pH equals a decrease in CO2. And so the more CO2 that we breathe off, so if we start to hyperventilate, if we're breathing more and more and more, we have the ability to get rid of more carbon dioxide. More carbon dioxide lost means that we have more of a increase in our pH. The body becomes more basic rather than acidic. So this idea that carbon dioxide can essentially effectively change the pH of the blood means that simply by breathing, we can regulate the pH in our body as well. And so as CO2 goes up, and so with too much carbon dioxide, the blood's going to become more acidic. And so our pH is going to start to decline. It's going to start to go down. I'm sorry, with too much CO2. With too little CO2, our pH is going to start to rise. So in this situation, with too much CO2, this could be from hypoventilation. With too little CO2, this can be from a hyperventilation. So this can occur in one of two ways in terms of the body. If we start to hold our breath, our pH is going to start to fall. Our blood is going to become more acidic. If we start to hyperventilate, we breathe more and more and more and more, that's going to cause our pH to go up. And as our pH goes up, we're going to blow off that CO2. In order to regulate this as far as how much oxygen do we have, how much carbon dioxide do we have, what's our pH level in the body, we have certain areas of the nervous system that are constantly monitoring this. And so we have chemoreceptors deep inside the medulla oblongata that is looking at the pH of the blood itself, receiving information from the carotid arteries as well as the aorta. So we have our carotid sinuses and we have the aortic bodies looking at this information, seeing when and where our numbers are changing. Because just simply a change in the number of hydrogen ions we have is going to mean that we have a decrease in pH. So if we have excess amounts of hydrogen ions, that's going to mean that we have a reduction in pH, which means that we're more acidic. Excuse me. And as such, that's going to cause an increase in respiration. We're going to try and blow off more CO2, get rid of more CO2 to try and combat this process. And so as things change within the body, those primary respiratory centers are going to make some changes. And so when it's looking at it, it's looking at more so the CO2 rather than O2. And so oxygen levels are going to be altered based upon that moment-to-moment basis as we look at carbon dioxide. And so rather than being either hypoxic or not hypoxic, having too little oxygen or not, doesn't really drive our breathing when it comes to kind of just moment-to-moment respirations. And so as we're doing things. So if we begin to exercise and our PCO2 goes up, so now we've got more carbon dioxide in the body, that means that our hydrogen ion concentration is going to go up, our pH is going to go down, and in order to correct this, as far as our respiratory system is going, in order to correct our pH, so to raise our pH, we're going to have to increase our breaths per minute. We're going to have to increase the amount of air that is leaving our body, and so we're going to start to hyperventilate. And so just think about going and exercising, going for a run, something like that. As you're doing so, your ventilation goes up. If carbon dioxide becomes too low, so now say we're hyperventilating for an unneeded reason, this is going to cause just the opposite. So now our hydrogen ion concentration is going to start to come down. Our pH is going to go up. And in order to correct this, we now need to slow down our breaths per minute. We need to hypoventilate. We need to change that respiratory process itself and decrease it so that we can now retain some of that carbon dioxide and start to raise our pH level. An increase in arterial hydrogen ion can also do this. And so I said this just a moment ago, that simply by altering hydrogen ion concentration, this can lead to having a low pH. And a low pH is going to increase our breaths per minute. And so we can have some sort of other reason why this is happening. Hydrogen ions can come from breaking down proteins. They can come from breaking down fat. So if somebody's on something like a keto diet, they're going to be relying upon proteins and fat for energy. That's going to lead to a decrease in pH, an increase in hydrogen ion concentration. And that's going to change what we have there. This can also come from a decrease in kidney function. And so we can have changes that are occurring elsewhere in the body, creating a metabolic acidosis that we're going to then fix by creating hyperventilation. So a metabolic acidosis leads to a respiratory compensation and leads to hyperventilation. As a result, oxygen levels themselves are generally a secondary trigger, and so this is going to become altered in a slightly different way. And so in terms of the respiratory process itself triggering this, we have to drop our oxygen amounts by upwards of 40% before we have any kind of trigger that's going to cause us to change or increase our respiratory rate. And so in terms of holding our breath, our breath holding itself will eventually cause brain cells to die if we're not getting enough oxygen. But in general, our process there for changing and increasing our oxygen uptake is going to take much less than that 6 minutes. And so if we're having to hold our breath for any period of time, beyond even for most people a minute, it's going to trigger an increase in respiration. We're going to look at this a little bit in the lab and see how breath holding and exercise plays a role in our respiratory rate. In addition to the monitoring of CO2 levels in the blood, we also start to look at things like just simply how are we moving? How are things going as far as respiratory itself goes? And so in our joints and muscles, we have proprioceptors there that are monitoring movement. And as we start to move, we don't want to wait until we're already, in a sense, out of oxygen or having a tremendous increase in carbon dioxide before we change our respiratory rate. We want to increase that as movement increases. And so we're simply going to make those alterations earlier rather than waiting for kind of the gases to start to catch up. Another thing that alters our breathing is on the process of inhalation. And so as we go do inspiration, we want to not allow essentially the lungs to overinflate. We don't want them to pop. And so there are stretch receptors, baroreceptors, inside the chest wall. So in aligning the pleura of the chest cavity, our visceral and our parietal pleura that's there, as well as in the lungs themselves that are preventing us from overstretching on inspiration. So as the lungs go from, in a sense, kind of being small as we're breathing in, and then we inflate them, we don't want them to get to the point where they've inflated too much and now they've popped. And so we don't want to get to that point where we can cause any kind of damage simply by doing inspiration. So we'll look at activity in the lab as far as how this alters our respiratory rate as well. And so with increased activity, we've all experienced this at some point in our lives, that increased activity is going to cause an increase in the rate of respiration. It's going to cause an increase in the magnitude, so how deep we breathe as well. And as that occurs, generally our oxygen and carbon dioxide levels are going to remain relatively constant. They're going to stay the same kind of no matter what we're doing. Certainly we can overexert ourselves. We can do too much and we're not necessarily able to keep up with our oxygen and carbon dioxide levels the way that we need them to be. And we're going to start to feel fatigue. We're going to start to feel that we can't keep on going. As we then rest, as we become more sedentary in a sense with decreased activity, you sit down to relax, you sit down to do some schoolwork, things like that, then our respiratory rate's going to decline. We're going to start to breathe shallower. And again, this is going to match our body's needs of oxygen and exhalation of carbon dioxide with the amount of use that we have going on for metabolism within our body itself. And certainly disease can start to play a role in there as well. And so if we have any kind of metabolic disorder that is changing things, our respiratory rate may stay elevated. Our depth may stay elevated simply because we have other things that are oftentimes changing that carbon dioxide level. And that'll do it for respiration. We'll see you over in lab.